This is the new matrix for January through December 2019, and Trish McMean and myself and several other managers met with Cindy Rhodes several times to try to tweak it a little bit so that it pertained more to surgery, pre-op, PACU, SACU, to us. And so I think she did a great job of doing that. There was some different verbiage in there. Rather than just the patient, it says patient, family member, coworkers when it's talking about certain things like communication. So we'll get through it. But I just want to stand on my soapbox for a minute and kind of explain the purpose of this matrix. The nurses represent probably the largest professional group in the hospital. And Jan Keys, our Chief Nursing Officer, and the powers that be, want the nurses to take a leadership role. They want us to come up with ideas and projects to help our workplace be more efficient, to help patients have a better experience. And that is the main purpose of this. So if you want to come in, clock out, do your job, and go home, you can check all the number 1s and 2s. That's doing your job. That's just the basics of what we do every day. If you want to step up to the plate, be a leader, be a mentor, then check the boxes in the sections of the 3s and the 4s. That's where you have to serve on a committee, compile a system for checking our data, checking each other to make sure that we're all doing the right thing, and furthering your education. We'll get through it. I can't think of any other examples right now, but the 3s and the 4s are the leaders and the mentors, and hopefully that's where the money is going to be when we budget this and start hopefully getting paid for this paid for performance. That is the goal. So it's your choice. The ball's in your court. However y'all want to do this matrix is up to you. And I know it is long and complicated, so let's go through it kind of page by page and interrupt me if you have questions. So on the first page, it talks about the 5 core competencies, same as before: customer-focused care, cost-effective care, communication, competent care, and compassionate care. And within those 5 core competencies, there are 4 with specific competencies, and that's the section in red. And those are the core competencies that the hospital gets a score on via the HCAPS. It is the patient's experience, their satisfaction, CLAPSIs and CAUDIs, how the hospital as a whole is doing in infection prevention. And since we don't really get HCAPS for the OR, we are clumped together with the floors and the units that we send our patients to. May not be fair, but it's the way it is. But we can impact HCAPS by smiling, by being pleasant with the family members that we see in the hallways. That 10 minutes that you talk to that patient in pre-op, talking to the families every hour. There are certain ways that we do impact that. So let me figure this out. So down here, core competencies at the bottom of this page, the customer-focused core competency is the HCAPS. The cost-effective one is exceptions, and we'll get into that a little bit later. The communication is bedside shift report and hourly rounding. The competent care is infection prevention, CLAPSIs, CAUDIs, and hand washing. So on this year's matrix, the scoring is the same. But on this year's matrix, as we go through it, you'll see that if you check all of the number 1, the boxes in number 1, that's your score. And then it explains in box 2, well, let me get to the top of the page, sorry. It says if you cannot complete all the boxes in section 2, then you will receive the points from the previous section. That's the same as it was before, but I don't think it was explained very clearly. So hopefully that will make a little bit more sense. All right, so at the top of each section, let me go back. Whoop. I need somebody to work the computer for me. At the top of each section are the attestations. Those are the same as before. Read through them, make sure you are willing to do those. If you need the policy, we'll get you a policy so that you can read through that. Initial those. Then in the, I don't know what color that is, mauve box, is the first core competency. And this is the HCAPS I was just talking about. It is patient satisfaction. Again, we do our part by helping lost visitors or lost family members. Be aware that the patient's families are within earshot, especially if you're sitting in the LOL. The families come through to see their loved ones in PACU, and they're sometimes standing in that hall looking lost, and they hear us down the hall cackling. So be aware of that. Get up, go help them, smile, offer to take them into PACU. Update the family regularly and explain things to the family. Explain the process. If they've never had surgery, they don't understand how they're going through the flow and where they're going to end up and where their loved one is. Under Roman numeral 1B, number 1, your coordinator may ask you to explain HCAPS. If you don't fully understand it, Google it. It's on Google. Ask your coordinator, ask your manager. Learn about it yourself. Be proactive. Let's see, we talked about the sections. Each section builds on the one previously, and you don't have to write anything by every single thing, especially in boxes 1 and or the sections 1 and 2s. Some of them have where they want you to list a date, list a name, give an example, but most of them do not. So don't get handwriting cramps by writing all that stuff. If you want to, that's fine, but you don't have to. But in sections 3 and 4, where it says B3, share examples, share ideas, share example, we need examples. We need concrete examples and some of the things you have to prove that you've done. So that's where you're stepping up, being a leader, being a mentor. Okay, next section. Let's see, I covered all this. Under B4, it says mentors. Mentors in regards to HCAPS. That doesn't mean just telling your preceptor that's in the room with you about it. It's that next step. It's above and beyond your regular job. We all have to precept. So list how you've mentored others. That might be through a huddle or through an in-service or a team meeting. 2 different teams can join together on Wednesday mornings and have a team meeting, and somebody can lead that team meeting with one of these ideas. The next category is customer-focused care, patient-family centered. We're in C. This is be aware of the, let me find it on the screen, sorry. Under 2. Under C2, be aware of your unit, department, systems, patient satisfaction scores. They're going to be posted in the glassed-in box outside of McMean's office.
It is right now.
Okay. And we'll update that as it goes. So again, ask questions, look at it, talk about it in huddles. Then, let's see, under C4, and I'm just jumping around to give y'all some ideas and examples. Mentors others to de-escalate stressful situations, provide an example. I'm sure there's lots of stressful situations out there, so take advantage of that opportunity when you're involved in one and document it. Write yourself a little note and then go back to this matrix when you have a moment and fill that in. This is a working process that you've got to kind of keep up with throughout the rest of this year. Any questions so far? Am I going too fast? Making sense? I know y'all know this probably better than I do. You filled it all out. In D, we're talking about clinical professionalism. And again, she kind of explains what that is. Maintain professional conduct in appearance and attitude with colleagues, physicians, patients, and families. So she's added that in with the colleague part for us. Since our patients are asleep, we can be very professional when they're asleep. And here again, give some examples of how you demonstrate a positive attitude in the professional conduct. Be a role model, be a mentor, and give some examples. Again, above and beyond what we do every day. There are the attestations for the next section. This is cost effective. And there's our next core competency. This one is efficiency at the workplace, being on time, leaving on time, meal relief, and not clocking in early. We get a scorecard for that, and that's why we ask y'all to not clock in before the 7 minutes before the hour that you're supposed to be at work, because it costs us money, but it also costs us scores on our core competencies. So that's why we watch it so closely. But these scores, for an example, if we have a stretch goal, a target goal, a threshold, and a below threshold. So if we get 12 points, then that meets our target. Everybody would get 3 points for that section. These core competencies collectively add up to 40% of the final score. So they're important. And it impacts all of us, and we all have an impact in it. So the next section is cost-effective resource management, cross-training, floating assisting other areas to facilitate patient throughput. Let me see what I wrote about this. This can be either where it says under B1, list an area of interest. If you're on the GYN team, you don't unfortunately get out much because it's such a busy service, but you might be interested in trying to cross-train a little bit into ortho. So when you have some downtime, let the charge nurse know you're going to go hang out in ortho, help that circulator in there, and learn something about that service. It doesn't necessarily have to be a different department. But if you're asked to go lunch relief over in children's, then that would count as well. Under B2, you've cross-trained. List the area and the unit that you did. Be specific. Give us a date. Okay. Under C, on to the next section, if I can maneuver. C is supply variances. This section talks about the importance of the cost of supplies and making sure that supplies are not expired and that you're returning supplies. Your coordinator may ask you questions about this section when y'all do your review. Give examples of how you take the initiative or measure to promote cost-effective care. You could attend a lean training, and for those of you who may not know what lean is, it is a system that has come to us from Virginia Mason Institute, and it is an approach to improve quality, safety, and efficiency. And from the patient's perspective, we hope that it adds value to their hospital stay. And from our perspective, we hope it reduces a workload. One of the lean projects that we did was the blood bank. They were getting instructions on our stationery. The floors were using different forms. It was very confusing on their end, so collectively several members of management and staff throughout the hospital, different units, met on a regular basis and came up with a standardized form, which is what we're using now. Currently, Trish McMean and several of the other managers and a few staff members are meeting to look at first case starts, getting the whole process down to a fine science. Chuck's in the pre-op area, documenting why we're late, to try to change that whole system or fine-tune that whole system so that everybody collectively is on the same page. If you're interested in serving on a lean project, then let one of the managers or McMean know, and we'll try to get you in there. Then, let's see, next section. Any questions about that so far? Y'all are so quiet. The next section is Roman numeral 3, communication, and there's the attestations for that. And the core competency below that is customer service. This one is the bedside shift report. And again, it tells you the target, the stretch goal, target goal, threshold, and below threshold. This one, under B1, well, under 3B, it explains the bedside shift report. And here again, this is an example of where our input led to this explanation so that it kind of pertains to us a little bit more. Bedside shift report, though a concept to exchange information specifically regarding a patient, can and should occur even in areas that may not have patients or patients that are asleep. A view of one's department, area, room, facility to ensure that it is ready for the next patient, procedure, or visitor is just as essential. So in B1, it talks about the handover report. That's our yellow sheet of paper that we all should be using. And there again, there's the example, yellow handoff report, lunch relief communication for coverage. Under section B3, it tells you to self-reflect on how you provide handover. When you're giving that report to that nurse, ask her if you gave her all the information that she needs. Get her feedback. And in 4B, participate and demonstrate a focused bedside report. Whoops. Participate and demonstrates a focused bedside report with detailed understanding of patient's plan of care. Explain how you demonstrate that. You can come up with any kind of a reporting tool that you would want to do that you could get with your coworkers, get with your teammates, and come up with some sort of an audit tool and use that to check each other off. When you lunch relief, did they give you that yellow sheet of paper? Do a little audit for whatever period of time. That can count as one of your projects. And you can do it collectively with your friends. Go to dinner, discuss it over a glass of wine, make it fun. All right, communication 3, again, this is still, this is part 2, technically, of that core competency. I did bedside shift. This is hourly rounding. We all did that little mock hourly rounding up on the 6th floor not too long ago. And this explains hourly rounding is a concept about going room to room frequently to check on patients and or families and initiate the 3 Ps, pain, position, and potty. We do that in the first 10 minutes when we're talking to the patient in pre-op holding. For some areas, this concept can still be achieved through a different practice that can still provide the same outcome of assisting patients and family. It can involve interaction and follow-up with patients and families outside your specific area in the hallway. Any interaction that enable one to assist, communicate, and be present is helpful in achieving hourly rounding. So again, take that opportunity if you see someone in the hallway that looks lost. And don't just point down the hall and say, elevator F to the left and down the hall to the right. If you have a moment, take them there. It makes a difference. Let's see what else I put in there. I think this is pretty self-explanatory. Under D3, follow up previous hourly rounding needs identified. So if you know that the patient is delayed in pre-op and you're still in the room with your previous patient, but you know that your next patient has been sitting in there for an hour and their loved ones don't know where they are, then pick up the phone and call and let them know why it is delayed. Ask your coordinator to do that. Call in pre-op holding, see if that nurse has done that. But communicate and make sure that family is aware that we are delayed. It may be the charge nurse that's told them, but be aware, think globally, communicate with your team, and make sure that that family member gets that communication. Next category is E, communication. Effective communication and exchange of information is imperative on a daily basis. This is not limited to our interactions with patients and families, but amongst ancillary departments and coworkers. Again, this is worked in there for us. Since our patients are asleep, we can't communicate with them very well. So use our whiteboards, our count boards. Make sure you write the staff members' names, CRNA, anesthesia, your names, your scrub techs, all on the communication board. There's a communication book in the lounge that Linda puts information in when we have in-services. Be proactive, go find that book, read what you missed in that Wednesday's in-service. Go to the huddles. Modeling the techniques found in our standards of excellence, and everybody, there's books out there, I hope everybody picked that up. It's been tweaked a little bit since it first came out, so there may be some changes in that. Under E2, updates whiteboard consistently and uses other communication means. This, consider a project or a process to enhance communication. Again, get with your teammates, get with your coworkers, come up with an audit process or a project that can help communicate between each other. And that can count as a project. Under E, I think it's the next page. At the top of the page, the second one down, understands and demonstrates managing up technique. This is praising another department, telling your patient in pre-op that we're going to take great care of them, and then they're going to go to recovery, and those nurses are going to take great care of them. They're going to go to the floor, and that nurse is going to check on them hourly. Think, again, globally and how we collectively take care of that patient. Don't be in a silo in just our department. The next section, I think, is pretty self-explanatory. All right, I think I've covered all that. Any questions? All right, we're to section 4, competent care. There's the attestations. There's the core competency on infection prevention. That's CLAPSIs, CAUDIs, and a next one on the next page is the hand washing. Oh, and by the way, the pages are numbered. Yay! That has helped tremendously. So we're on page 14. And the infection prevention bundle, that's explained down there. It's a combination of many processes to decrease hospital-acquired conditions. The utilization of bundles is one type of best practice to help reduce and eliminate CLAPSIs, CAUDIs, surgical site infections, and etc. All areas should be aware of, initiation of, and adhering to specific bundles and protocols. Infection control, sorry, I can't read. Infection prevention also includes hand hygiene, maintaining a clean environment, adhering to universal protocols, traffic control, which was put in there for us, managing and evaluating the area for issues of concerns that can lead to potential infectious threats. So this section talks about the bundles. You can write in here an explanation of what we do to try to prevent infections in the OR. We keep the doors closed. We wear covers over our cloth hats. We keep our mask up or off. We keep our arms covered as much as possible in the rooms. Be able to articulate the infection rates. That's under B2. In B3, there's a section, the second box, collects and compiles data. This can be a unit or a service line or department-based audit tool, and process must be shared with one of the managers or directors. An example could be the hand hygiene. We're already doing an audit. There is a list, a handout out there that has surgery opportunities as well as hospital engagement opportunities of different audits that you can be a part of, the mask up or mask off, the hand hygiene. You can go to the wound committees meetings. And I know it's hard to get everybody to a meeting, but hopefully if you're interested, let us know. We'll try to get you to at least the first meeting so that you can learn what the audit tool looks like and then come back to the department and audit that, whatever that is you're auditing, and get credit for that. There are lots of hospital opportunities in there. And again, if you want to come up with your own audit tool of something that you think would help the department, then bring that to the management and let's discuss it, and possibly let you do that. And again, get with your friends, make it fun. Under B4, mentors and educate staff about best practices. Go on the AORN website. Learn about what the best practices are. Lead a huddle. Do an in-service. Do a team meeting. We're to next section, competent care, infection prevention. This is page 16. This is the hand hygiene. This is part B of the that core competency. And we're already doing the hand hygiene audits. If you want to be a part of that, let Linda Gilly know, or one of us, and we'll make sure you get the correct paperwork to fill out. You have to do so many a month, but you're in there anyway, IDing your patients. So you watch your coworkers, you watch CRNAs, you watch the doctors, and mark down if you see them wash their hands. It's fairly simple. It can be worked in to your regular, everyday duties. Let's see, under D3, collects data on hand hygiene. There again, you have to be on a committee to collect that data, an approved committee or one that our leadership has approved within our department. Any questions about that? Crickets. Section 4E, this is infection prevention on equipment cleaning. That's pretty self-explanatory again. How do we know that the equipment is clean? Are we wiping it down? Do we have a tool to make sure that everything has been wiped down? Another idea. Under E3, whoop, I went too far. It says audit tool. Well, did I go too far? No. Yeah, ensures compliance. Audit tool and process must be shared with one of the managers to get that approval if you come up with an idea on that. The next section is leadership, license and unit specific. This is first section, doing your job, maintaining your license, getting your BLS. The next section, F2, maintaining your continuing education. Again, part of everyone's job. Assume responsibility for professional growth. If you attend a class, you subscribe to AORN or another medical magazine, you can discuss an article that you read in there. It doesn't mean you have to be enrolled in school, but you have to do something to check that box. Under F3, this section is assist with unit education. Not just precepting, it's the next step. We all have to precept. So how have you helped with education? Did you lead a huddle? Do an in-service? Did you help our educational department with the recent annual competency thing? Under the next section, it talks about Bls Acls Pals. Our department only requires that you have a BLS and your nursing license. So if you want to further your education, initiate to continue to enhance your education under F3, that could be that you got your ACLS or your ATCN certification. But to check get the full credit for number 3, you have to be an instructor. And it may not mean that our department needs any additional instructors, although we do need some BLS instructors. If you want to be a PALS instructor or an ACLS instructor, you can do that. Section 4, to get credit for that, 4 points, you have to be instructor of 2 things. This next section is your unit-specific certification on the approved list, which is another handout y'all have. This certification is, for us, CNOR. If you transferred to us from a unit or a ICU unit and you're critically cared certified, then count that. If you came from the ER and you're CEN, then count that. But this certification is one that has to be on the approved list. It's not ACLS, it's not PALS. It is a certification within your field. It requires lots of CEUs to maintain it. Like for CNOR, it's 150 for 5 years. Whereas ACLS and PALS, you don't have to get any CEUs to maintain that. You just retake the test when the time is up. So this one, there's no exceptions. It's got to be on that approved list. You can do any of them on the approved list if you want, but CNOR is the one that's directly related to us, obviously. The next section is Leadership Advanced Certification Education. Plan your professional growth. List some educational goals. Again, it doesn't have to be enrolled in a class, but what's your passion? What are you interested in? Maybe you want to research something that we do every day that you don't get to see and learn more about it. Put that down. Put the resources you use, how you got that information. You seek educational opportunities to enhance your clinical performance. List the areas of opportunities. Again, the same thing. You don't have to be enrolled in school, but constantly be researching and learning different things that we do. Under G, I think we got any questions about the difference between ACLS, PALS, and CNOR and which section you put those in? Everybody got it? Okay. Under G3, you must have at least 2 of those requirements. You don't have to check every box. This is the only exception to this. Under G3, you only have to check 2. So if you're CNOR, you've maintained that certification, and then you attend a conference, you check that box, and that's 2. Or you could share a literature review with a colleague and go and be certified, or go to a conference. You just got to do 2 of those. And then under section 4, same thing. You just got to check 2. Under leadership professional growth, this is, hold on, let me go down to 2. Become a super user for new products. On the previous matrix, this was kind of overlooked. We graded that previous matrix very leniently. And this next year, this next go-around, it's going to be a little bit more, we need a little bit more specifics and dates since we have the majority of the year to get that done. So provide a list of the products that you are a super user, and then you have to do an in-service or a huddle or a team meeting with that in-service. It needs to be something that the whole department can benefit from, or at least a couple of teams, not just your own specific team. Actively enhance your education. Attend an academic class or other educational opportunities. Articles, in-services. Again, list those specifically. All right, next section. Any questions on that one? Leadership, committee meetings, and quality project member. And again, I know it's hard sometimes to get to these meetings. We've got shared governance, lean meetings, unit councils. You can come up with your own committee that would be on a project, again, with your team members, with your coworkers, to solve something that would be beneficial to the department. Under I3, you are a leader in that quality team and provide information on that. And in I4, you are developing a presentation. Again, I know I sound like a broken record. Huddles, in-services. Under J, we've got leadership, clinical leadership, preceptorship, and mentors. Under J2, it talks about plans to attend a Preceptor Workshop. This year, Amy Tillett is going to lead a Preceptor Workshop for us. So we'll get the word out. She'll do it several times. We'll try to get as many of y'all there that want to attend. Last year, it was, I believe, an HR meeting that was kind of limited, and they didn't offer as many as we'd hoped, so we didn't have that opportunity. All right, under K, leadership, clinical, teamwork. Participates as a team member on a committee meeting. Lists that committee meeting. Again, that list that y'all have a handout, lots of opportunities within our department and within the hospital. Under K2, engages and takes initiative in assisting others, covering lunches, acknowledging visitors, providing information. Maintains a professional and positive approach. Part of this is doing your job. You're assigned to a lunch relief. But if you're down, go to the charge nurse and say, hey, I'm free, I'm extra, do you need me to go help someone? Or tell the charge nurse, you're going to go help your coworkers in such and such room. Under K4, halfway down, it says assist with the interview process for new hires. If you're interested in being a part of that, let me know. I do most of the interviews, and I'd love to have somebody join me. Under 4, competent care. This section is an area that we can put our own specific things for 6211. So if you're not with 6211, you may have some additional things added on that, but most of this is surgery. So medication safety, timeout, surgical counts, informed consents, doing pathology the correct way, guaranteeing the sterility of instruments in the room, and then transferring patients to PACU. And so if you're not in 6211 or you're a different area, you need to get the matrix that came from your area to actually turn in, because it would be different. Under section M, same thing. This is basic equipment. So what I've listed here is things that are in the main OR. Miller I has different things. The 6th floor may have different things. 4th floor may have different things. So be sure to use the matrix that your manager gives you with the correct things listed. All right. Any questions about that? Section N is clinical care. Again, we can put our own things in here. So this pertains to the main OR, most ORs, but Miller I, again, has some different things in theirs. It's prevention of a retained foreign body, maintaining normal body temp, maintaining normal blood volume, prevention of DVT, prevention of positional injury, universal protocol. Back up 1 minute. Under M4, help create a safe protocol policy and teaches others, keeping up with best practices. Again, research, go on AORN, learn what the best practices are. Let your coordinator or manager know if you're interested in helping with tweaking our policies. We have to review them every year. So that's something we'd love your input in if you're interested in being a part of that. Okay, back to N. Let's see, anything in N? Nope, we're good in N. Okay, so O is, again, something that we can tweak specifically for our area. So make sure that you have the correct matrix form because it may not look the same. Yeah?
So back up on N.
Yeah.
About the foreign body and normal coding and everything. Is there like do we grade that in any way? Is there any way for us? Because I've always been curious, like what like our rates are of like DVTs and things like that. Is there a way that
We do get that number, don't we? Can we post that in the cabinet?
You track it mostly in packing with
But foreign body or retained sponges,
the harm events on the scorecard we check that.
Okay, did you hear that? The harm events would be on the scorecards?
okay, is that gonna be posted outside your office?
Yeah.
And the quality it goes.
Hospital-wide quality meeting, yeah, we can get that in the,
And only specific things
GYN?
Yeah, that.
GYN.
hysterectomy,
Yeah,
uh,
for post-op infections. There's only certain ortho, GI, GYN, is that it? Okay. Yeah, well, we'll get those posted up in the glass cabinet. Thank you for asking that. Under, did we finish O? Oh, so O is competent care, clinical care. And again, in that blue box, we can put our own specific things depending on which unit we're in. So these relate to the OR, cardiac emergencies, trauma, surgical, massive transfusion protocol, malignant hypothermia. I think y'all's handout says, there was a typo. It said something else. But anyway, it said malignant hypertension, but it's malignant hypothermia. And donor cases. So this section relates to those. The next section in, oh, no, P, I don't know my alphabet. Pain management. This was a kind of a sticky point last time because the CRNAs manage most of the patient's pain for us. But when you're in pre-op, you obviously can ask the patient if they're in pain, assist the patient using relaxation, ensuring comfortable positioning, get them a pillow, get a roll-up underneath their knees, get them a warm blanket. But pain management does not necessarily need to be pharmacological. So while a lot of this does pertain to anesthesia, they've tweaked it a little bit so that it can somewhat pertain to us a little bit more. You can discuss with the patient when you're in pre-op about post-op pain, explain to them that they need to tell their PACU nurse on a level of 1 to 10. If they're in pain, that PACU nurse will ask them. You can explain that to them. They may be getting a block, so you can explain to them with blocks. Sometimes they need less oral pain medication. Just be engaged in that conversation with the patient in pre-op. Section 4Q is pressure ulcer prevention. And here again, this is positioning the patient, using the Mepilex, understanding ostomy care, knowing who to call if you need them, give examples, give details if you have to use the ostomy nurses. The next section is clinical, oh, did I just do that one? Yeah, no, compassionate care, awareness of the patient. We are on, oh wait, back up, sorry, I'm going too fast. Under Q3, it says proactively, it's up one more, the very last one of that section right there. Proactively participate in a monthly skincare audit. That would be one of those meetings that you have on your list for wound care. And they have a specific audit tool that you would have to get and then audit that. Get with Linda or Linda Gilly or one of us if you're interested in being on that committee. All right, which is section 5. We're almost done. We're on page 31. This is awareness of the patient. I've lost my spot. Here we go. This is seeking policies and procedures to adhere to making decisions. Developing the ability to anticipate the needs of the department or your coworkers. Maintain a safety physical environment. Explain how you do that. What do we do to make sure that patient doesn't fall off the operating bed or off the stretcher? Under A3, that's pretty self-explanatory. Give examples of best practices utilized. Again, research that with our AORN. Under section B, team concept and focus. Contributes to the team communication, to the department meetings. If you can't go to the Wednesday morning meetings, be sure to read it in the book. But be engaged, ask questions, be a patient advocate. Under B2, again, team communication, huddles, meetings. Strive to include the patient and family in the discussion if it's something that you can discuss with them in pre-op. Actively participate in safety initiatives and huddles. Under section 3, share examples of the times you initiated team rounds. Again, team meetings, huddles, something that you brought to the group. All right. Roman numeral 5C, family and patient education, understanding of home plan of care. Some of this, again, doesn't really pertain to surgery, but you can certainly discuss with your patient in pre-op if they're going home, if they're staying in the hospital, what is their plan of care. They might need physical therapy. Just engage in that conversation with them if you know what it is. And then sign at the bottom of the page. Any questions?
You want me to do the scorecard?
Yeah. McMean's going to go briefly over the scorecards. You got about 10 minutes.
Yeah.
Sorry.
I won't take too long. Let's see, so I posted outside my office our most recent scorecard for our unit. So Department 6211, it's current as of February 27th. And these are the mauve colored items as the other Tricia went through the matrix. So if you look in this section, this is what our stretch goal, our meet expectations, and meets minimal requirements. So I'll go over this, well, let me see. Okay. Patient, this is new, this survey started in July, so there's not a score or trend line on that right now. But under nurse communication, to meet our stretch goal, we have to have 31.5, meets expectations 15.5, and a meets minimal of a 9.2. So these are the scores as you go across for each month. So in January 2018, we had a 22, and so it keeps going each month, and then this is averaged out at the end. So in nurse communication, our percentile is 4%, which is not good. We need a 9.2 to meet the minimal. This comes off the patient scorecard, and I'll scroll down because we don't have an individual scorecard for our unit. We're lumped in with the nursing departments that we send our patients to. So we have BEH, MICU, NNICU, North Wing 6, North Wing 7, North Wing 8, North Wing 9, SICU, STICU, and then BEH surgery. So as you go across the environmental cleanliness percentile, right now we have an 8. To meet the minimal has to be a 37.6. The hourly rounding, we're at 59% right now, so almost to the point where you average all these scores out to meet that 60%. Same with the bedside shift report. We're right now at a meets the minimal. To get a meets expectations, we'd have to be at the 75th percentile. Down below, this is our true actual hand hygiene scores. So these are our auditors that are turning in monthly data. Our hand hygiene to meet minimal expectations is 80%. Right now we're at 83.23. So if you'll look at the averages from the new tool started in September. So we're close to being able to meet expectations on the CLAPSIs and CAUTIs, so your central lines and your Foleys. We meet expectations. We've had 2. Our score's a 2 right now, and for CAUTIs is a 12. Harm events, total harm events, meets minimal would be a 20, and we're at 14 right now, so we have to get to an average of 10. Our true unit, this is us, not anybody else. We're exceeding our stretch goal right now for worked productivity, and that looks at the true hours that are given to patient care. So that takes out your paid productivity has PTO in it, it has education in it, it has any FMLA hours, anything that we're paying to the staff, and the work productivity is true hours of care based on minutes in the room for surgery. So right now we're at 117%. Our minimum would be 100, our meet expectations is 102, and our stretch is 104. We look really good, and a lot of that is we've got so many people in orientation. So if you look at our paid productivity, it's not quite as good as our worked, but I think we do a fantastic job right now of keeping an eye on our hours. The exceptions, if you're in other departments, they're looking at early ins, late outs. I'm trying to remember all the exceptions. The missed meals is what we're being calculated on right now because our schedules are so flexible. We don't work like the floors where everybody works 7A to 7P and then or 7P to 7A, where we have different shifts and we flex people in and out based on how many early starts we have. So right now we're only being looked at for missed meals. They want our average to meet a minimum be 15, to meet expectations 12, which we're right on the cusp of that, and to meet the stretch would be 8. And what the goal of that is, you all deserve a meal break, a 30-minute uninterrupted break if you've worked 6 hours worth of time. And as we drill down into it, most of our missed meals, it could be you've come in on call and you've been here 6 hours and there's not somebody, like the specialty teams is when this hits. So our endo team, our cardiac team, where there's not somebody to come and relieve them. Hopefully, we're helping to get breaks to those staff members of the specialty teams when they do come in, if they have back-to-back cases, that we can at least help them with that piece of it, find a good time to go in and give breaks and lunches too. And I think that's really it on the scorecard. So when you look at the bottom, right now our total nursing matrix score is 1.86. So as you go through those sections, the scores are off to the right here on what you would fill in if you were scoring it today. Does that make sense? It's kind of tough to explain this. I'm hanging this outside our office, or outside the office in the glass window. If you want to take a look at it, we can look at it more together. And as I get them, we'll just keep on updating it. And you'll see in this line where it says admitted patient experience, it has that final with a question mark. It takes some time to get those answers back, so you're still receiving data for a month to 6 weeks post, so this is not finalized from August. I guess it's not. They haven't finalized the numbers here, so they could possibly change. Clear as mud? I think that's it.
Thank y'all.
Thanks. Have a great day. Very busy day today. I don't know how to, this one's tough to explain.
Be sure you signed in, please.